All right, everybody. Thank you so much for joining us on a Saturday, 11:30 Central Time here. So wherever you are, thank you for joining us today. Today, we got about a 1 hour presentation. I'm keeping it relatively simple. The title of this presentation is Soft Tissue Management Around Dental Implants, Flattening the Curve. So we're just going to be talking about some of the basics of soft tissue grafting around dental implants, and specifically what you see here on the title slide here, where we have receding gum tissue exposing implant components. So what do you do? How do we prevent it? What causes it? And that type of thing. So a little bit about me real quick. David Wong, in private practice in Tulsa, Oklahoma. Full-time perio practice. So that's a little bit about me. So if you have any questions or anything like that, we'll have a Q&A when we're done. So soft tissue management around dental implants. You know, these cases on here are kind of what every clinician's nightmare is. Sometimes there are cases that we inherit, sometimes there are our own cases. So I think first and foremost, you know, learning how this happens and how to prevent it is of course very important, but it doesn't stop these cases from coming in. So we're going to talk a little bit about prevention, but we're also going to talk about solutions. And I think that's something that a lot of you all will hopefully be interested in today. I don't really check emails or anything like that. So if you guys have any questions after today, which hopefully you will, since we're only going to be talking for about an hour, just contact me on Instagram. I've got 2 accounts. I've got a personal account, david.wong.dds, and then I've got a more clinical account, Plaque China. So feel free to direct message me or follow me there, and we'll get all your questions answered, I promise. So starting off with one of my favorite quotes, I not only use all of the brains that I have, but all that I can borrow from former President Woodrow Wilson. This is just to tell you all, nothing that you're going to see here today has been invented or developed or even improved upon by me. This is basically literature-based approaches that I have found that work really well for some of the implant problems that I'm going to be showing you. So, okay, let's start. 4 factors affecting implant aesthetics. So what are the 4 factors? When we're talking about implant aesthetics, sometimes we don't have a choice as to how the patient presents, like cases like this where they have trauma, right? So existing gingival levels is the first thing that dictate our implant aesthetics. It's the patient's presentation. Number 2 is going to be how the patient's tissues respond to our surgery and our prosthetic procedures. Okay, sometimes they don't respond like we want them to. 3rd is going to be in our control, which is going to be implant depth and position, where we place the implant. And then lastly, it's going to be how we manage the soft tissue with the abutment and the crown. So those are the 4 main factors affecting implant aesthetics, and we'll talk about those. So real quick, when we talk about soft tissue around teeth versus implants, I always have to remind people, so grafting around implants is exponentially more difficult than grafting around teeth. Grafting on a tooth surface, for example, is way easier than grafting on an exposed titanium surface. Your interproximal bone levels around teeth is much more favorable compared to implants. The papilla size around teeth is bigger than implants. The location of the CEJ is more favorable than around teeth than it is than the abutment fixture margin on implant. So there's a lot of things that teeth have as an advantage over implants, but because implants are so popular now, we see so many, we're going to see some of the same soft tissue defects. So what I like to start off with is a short discussion about what exactly is soft tissue management. The definition of management is, number 1 from the dictionary, controlled direction. Yes, keep in mind the word controlled. We're trying to control things. Is this controlled direction, right? We have 2 implants here. Patient wants this corrected aesthetically. Is this controlled direction? I don't think so. What I think we're doing a lot of times with these implants is really rescue. Definition of rescue is to free from danger or distress, or to recover. And I think, unfortunately, with a lot of these cases, we're not talking about soft tissue management anymore. We're talking about rescuing. So on 2 ends of the spectrum, on one end, you have a case like this, tooth number 8, which versus what I just showed you. That's the difference between management on one end and rescue on the other. So let's get started. Going back to our 4 rules of soft tissue management around implants, let's start with number 1. Have a plan. If you fail to plan, then you plan to fail. You have to know your biology and let it work for you. So what I mean by that is if you look at the picture on your left versus the picture on the right, you should be able to tell which case you want to treat, right? Just based on tooth anatomy and the gingival biotype and thickness. So based on this slide alone, immediately if I said, hey, which case would you want to take for an implant case, all of you should be thinking, I want to take the case on the left, right? And we don't need x-rays or anything like that. All we need is a clinical presentation. And why do I say you want the case on your left? You want short square teeth over long tapered teeth. You want no black triangles versus pre-existing black triangles. You want thicker tissue versus thinner tissue. So these are things that you can tell just off a real quick photograph here. So know your biology, let it work for you. We also want to know what other procedures outside of soft tissue grafting are available to us, such as ortho extrusion to improve the interproximal bone levels, which improves our chances of success in soft tissue grafting. We also have to look at emerging techniques and technology, such as the partial extraction therapy, where we leave the root shield on the facial to protect the facial bone to keep it from collapsing. And finally, we have to consider other things like the sequence of treatment, which in this case would be immediate implant placement followed by perhaps some soft tissue grafting. So even though today we're going to talk about soft tissue grafting exclusively, keep in mind there are other ways to go about changing the circumstances of your implant placement and position to where you'll have a more favorable soft tissue outcome without actually doing any grafting, or at least with doing minimal grafting. My third rule is to graft early. So this is one that we can debate later, but generally speaking, whenever we have cases like this here, where we have a soft tissue defect as well as a hard tissue defect, which do you correct first, the soft tissue or the hard tissue? Generally speaking, I like to do the soft tissue first. That's just me. Okay, and I'll have some documentation to support that here in a second. Number 4, be patient with restorative treatment. And this is a big one. So for upper anterior teeth, specifically central incisors, we got to be patient. A lot of times people just aren't patient enough using custom healing abutments, custom impression copings, and provisional restorations and that type of thing to train the tissue, right? Everybody gets in a hurry to just go straight from the healing abutment to the final impression, and what happens there is you end up abusing the soft tissue, causing it to blanch, and subsequently it will want to recede or become inflamed. So we got to be patient with restorative care. So comparing the 2 photographs here, you want the one on the right. So let's go over a case to talk about soft tissue management with minimally invasive solutions here. So here, as you can see, we've got a horizontally fractured tooth number 9. It's non-restorable, it's hopeless. On top of that, we have a periodontal defect on the mesial aspect. So how do we manage this? Okay. Now I will say this, if your answer is let's take the tooth out, do an implant immediately, provisionalize it immediately, that's fine. Okay. That's something that you're going to see a trillion times on the internet and a trillion times on the podium. Once we get back to normal, you'll see cases like this. But I'm going to show you a way just to demonstrate proof of principle, what happens when you sequentially do things the safe, predictable way and get an equally acceptable result. So the challenges of this case, we have a horizontal root fracture, periodontal defect. If you look closely, there's a periapical radiolucency, and mostly we have poor interproximal height of bone because of where the horizontal root fracture is. So this is her smiling. So the question I always have for the audience whenever I'm speaking is, does this patient have a high smile line or a low smile line? For her, and we'll discover this here in a bit, we consider this a high smile line because of the prominence of the papilla. At any rate, going back to what I said earlier about long tapered teeth, Long tapered teeth are really hard to replace because the tissues are generally thinner, more delicate, more prone to gingival recession. And as you can see here, we have a dark triangle present already. So whenever we talk about a high smile line, when we look at Steve Chew's paper here, in the smile, the papilla show about 87 to 100% of the time. And the average papilla height of maxillary anterior teeth is about 40% of the root length. 40% of the tooth length. So that's, gives you a guideline on how big the papilla should be. Also gives you a guideline on how often they're visible in the smile, even though the lip may not come all the way up past the gingival zenith. So for this case, we chose to start off with an atraumatic extraction. And rather than just do a basic socket graft like you see here, what I decided to do was combine a hard and soft tissue graft at the same time. So once we got to this point with the basic socket graft, because there was a facial plate, but remember there was also a mesial periodontal defect, what I did is actually scraped out the coronal half of that graft and replaced it with a modified socket seal graft, as described by Carl Misch back in 1999. So in this situation here, we take just a small little trephine and we go to the right tuberosity, and we simply just take out a small conical shaped graft. What's neat about this type of a graft is that half of it's bone and half of it's soft tissue. So in this situation, the trephine's perfect because it fits, the graft will fit perfectly into the socket, and we have no gaps or anything like that. We just simply secure the graft with a few figure 8 sutures, and we're done, right? So in this situation here, it's not a whole lot different than what you would do with a basic socket graft, except now you're just taking a little bit of graft from the bone and soft tissue, from the tuberosity. So what we do then is we allow the site to heal about 4 months, and then we come back in and now we start our surgical planning. So like a lot of you all, I like to use guides because guides allow me, especially in situations where we have an abundance of bone, it allows us to put the implant where we want to. It also allows us to utilize a flapless approach. So here we're utilizing the 3-2 rule of placement, where we're putting the implant 3 millimeters apical to the gingival margins of the adjacent teeth, and then we're going to put the implant 2 millimeters lingual to the facial plate. So that's the 3-2 rule, and as you can see here, you can see how the implant's significantly placed more lingually compared to the adjacent central incisor. So here we are, flapless placement. From the radiograph, you can see that the periodontal defect has been filled, and this is the facial of the implant after it has been placed. So after the implant's allowed to heal, we put on a provisional restoration. And what you're going to notice here is the point that I was trying to prove with the long tapered tooth morphology. Very delicate papilla. So even with all the soft tissue grafting and everything, it recedes and exposes the black triangle even more. Now, some people would say, well, you should have done an immediate implant or whatever. But once again, that's a lot easier said than done, especially in the midst of a periodontal defect as well. So this is the part where we have to have a discussion. What do you do now with this big black triangle between number 8 and 9 and between 9 and 10? So what you do is nothing. That's what happens. So in the smile, once again, 87 to 100% of the time, the papillas show. So as you can see from the before to the provisional, you can definitely tell that something is not right. The tendency in dentistry, though, is to use your hands, right? You want to use your hands and fix everything. But the wise thing to do in a situation like this is to do absolutely nothing and let Mother Nature do its thing. And let me show you what Mother Nature likes to do. In 2 years, the papilla fills in back to pre-op levels, and I'll show you that. Papilla volume increases in average of 0.375 millimeters after 1 year. This is a very classic paper from Dr. Uli Grunder, something that you'll see quoted quite often. So the lesson here is to take our dentist cap off and try not to fix things immediately and just to give it time. It's really hard for us as dentists to be patient and to give things time, but this is something that it's going to require. So if you look from pre-op to 4 months where we have the big black triangle to 2 years, you can tell that even though she's smiling even bigger, aesthetically we're in a pretty decent situation. So let's move on. So that is management. We're going to talk about a little bit of rescue, and that's where we're going to pick up next. So in a situation like this, we have a patient, she got into an accident of both some lower incisors. We have a big hard and soft tissue defect, mostly in the horizontal direction. Is soft tissue grafting indicated, and when? So let's talk about what we're looking for when it comes to soft tissue. So first question is how important is keratinized tissue around implants? So common assumptions that we have about keratinized tissue around implants is that you get less inflammation, less bleeding, less plaque, less recession, and less crestal bone loss. Is that true? Okay, so that's what we need to look at. So when we look at this paper about the keratinized tissue around overdenture abutments, what do we decide? What do we find? So when we have less than 2 millimeters of keratinized gingiva, you do get an increased amount of recession, increased amount of clinical attachment loss, increased plaque formation, which subsequently leads to more bleeding and inflammation. So it's exactly what we would think when it comes to overdentures. What does the literature say when we talk about a systematic review? When we look at all the different papers, what do we discover here? And unfortunately, the literature starts to get a little bit more blurry because systematic reviews require, the same inclusion criteria for what we're trying to talk about, and there just isn't enough. Isn't enough studies out there. So less than 2 millimeters of keratinized gingiva here did yield a higher plaque index and a higher gingival index, but it had no effect on probing depth or bleeding on probing or implant survival. Okay, so the conclusion here is not enough information. So keep in mind here with these systematic reviews, there just often is not enough papers to have the same inclusion criteria to make the paper meaningful. This is an interesting study as well, looking at J. Perio, where not having enough keratinized gingiva did not confirm increased recession, and also did not increase and change the way patients had pain or anything like that as well. Aesthetically, though, what was interesting is that patients preferred keratinized gingiva around implants, and we're going to go back to that. So remember that. Aesthetically, patients prefer keratinized gingiva around implants. I also want to point out that in this study that the patient's oral hygiene was immaculately maintained. So we know that, whenever people have extremely clean teeth and take really good care of their teeth, you may not need a whole lot of keratinized gingiva. So the problem there is that how often do we have patients who take really good care of their teeth? So that's always the debate. At any rate, whenever we look at just a few other studies, I looked at 12 of them. Six of the studies said that keratinized gingiva is important for implant health. The other 6 were, maybe, maybe not. We don't know yet. What about gingival biotype? So in general, we consider 2 types of gingival biotypes. You're either thick or you're thin. What do you want? Well, nobody wants to be thin. Everybody wants to be thick. And why is that? The benefits of a thick gingival biotype is that you have less recession, less inflammation. And the point I'm trying to make here is improved vascularity and graft stability during bone augmentation procedures. So that's the reason why I say rule number 3 is graft with soft tissue early. Do that early on. And people do disagree with me on that, by the way. It also improves your aesthetics when you have a thicker gingival biotype. Another thing we've looked at in implants in soft tissue is the importance of the vertical gingival thickness. What is that? So after you place your implant, you just measure with your probe, how much soft tissue do you have above the implant platform? And that has become more and more important as we study these things, because thanks to Thomas Linkevicius and his group in Lithuania, we know that thicker vertical tissue is associated with less crestal bone loss. Who doesn't want less crestal bone loss, right? Exactly. So that's why we want thicker vertical soft tissue as well. Now, we don't have time to go over every single soft tissue option, because this is a chart that I made for a textbook publication a couple of years ago. And even if we look at using the patient's own skin and human dermal skin or acellular dermal grafts, So even if we look at your, autogenous tissue versus an allograft, this is how many different options we have, right? It's crazy. We can go palate, tuberosity, acellular dermal graft, or whatever else. You have pedicle and free grafts. You have inlays and onlays. There's so many different things that we can talk about. So I'm going to keep it simple today, and we can have a further discussion later on, hopefully when I see you guys in person one day. So this is all in our textbook from Dr. Dwayne Caratu. It's called Implant Aesthetics. My chapter is in there as well to go over some of these these techniques in more detail. So when we talk about soft tissue management, first and foremost, I tell patients, we have got to get you healthy, okay? That's the biggest thing. We don't want your gums to bleed. We don't want you to hurt. We want you to be able to eat what you want. These are all things that are very important. We also want you to be comfortable, functional. And lastly, for me, is aesthetics, right? Whenever we're talking about soft tissue. So they may come in for an aesthetic problem, but the big thing now is getting them back to health, and then we can worry about the aesthetics later. So let's talk about some of this. So going back to our case here, what I said earlier, do the soft tissue grafting earlier. So that's what we did. And this is also, this technique you're going to see in this paper by Siebert and Salama in June '96. So graft early. Once again, we graft early because we have less recession, less inflammation, and for me, you have improved vascularity and graft stability during bone augmentation procedures, and it just looks better, okay? So here what we've done is I took a free gingival graft from the right side of the patient's palate. It was full thickness, as you can see here, very thick, and then all we do is we secure it to the recipient site, which is where the teeth were avulsed. So here we are. This is your free gingival onlay graft, and the purpose of this is to thicken up the tissue so that we can have not only better aesthetics, better soft tissue contours, but it also provides more vascularity and stability to our future ridge augmentation. So 12 weeks after we place the free gingival graft, we can do our ridge augmentation procedures, and I flash forwarded here for the sake of time. But eventually what we have here is a couple of implants with an implant bridge, and you can see what stability a free gingival onlay graft can give you. It gives you a lot of keratinized tissue, great soft tissue contours. Most importantly, though, once again for patients, it's healthy, and it looks like it's going to be a lifetime of health here. Very, very nice pink, healthy, maintainable tissue. So this is 2007 compared to 2015. This is 8 years later. What do you do about failed implant sites? So this is a guy that came in. Originally, I just got a radiograph from his dentist that said, hey, I think we have a failed implant. Without any other information, I couldn't really tell what was going on. So when he came in, we took a clinical photo, and this is what you see. You see a large fenestration right in the facial aspect of the implant. And you can see the threads exposed already. So what do you do in this situation? We have an implant failure. So this is the sagittal view of the implant on the CBCT. So here again, when you remove the implant's going to pop out very easily. The problem is it comes out to the facial. You're eventually going to need a ridge augmentation. Rather than do the ridge augmentation right then and there, what I did in this situation was just another thick free gingival graft. We let that heal up, and this is what the graft looks like. Here's what it looks like at 2 weeks. And then we just let it heal up for, once again, we let it heal up 12 weeks, and then we do our ridge augmentation procedure. Our ridge augmentation procedure, just to kind of share with you my technique, I won't go over it in too much detail right now, but we started off with some cortical perforations. We harvested some PRF, and here's a tenting screw for some stability and space maintenance. We did some bone scrapings with the bone scraper, and then you can see the PRF membranes on the left side. So what we're doing here is making some sticky bone or steak bone, utilizing a combination of freeze-dried bone allograft, mineralized cortical powder to be specific, combined with some xenograft, combined with the PRF to make some sticky bone, okay? So this is what it looks like placed into the mouth. It's overbuilt, but you can see the nice initial stability of the particulate. that you get with sticky bone. Then we cover it with a couple of membranes and get primary closure. Okay. 6 months later, okay, that's how long we waited for this ridge augmentation. Now we can come back in with our surgical plan. As you can see here, we have plenty of bone to place our implant in the proper position, so it's kind of lingually placed so that we can have a screw retained restoration. And here we go with the surgery. Implant goes in pretty uneventfully, and then here we are healed up. We went ahead and covered the implant, so it's a two-stage approach. And then at this point right now, this patient is just presently in a provisional restoration, and his oral hygiene is still terrible, but it's fine. He's going to turn out fine. He's also going to have his adjacent teeth restored as well. So his final result, I'll report back to you later. But so far, this is how I've chosen to manage the soft tissue. Now, what do you do about mucogingival issues around implants? So when it comes to gingival recession around implants, here we have two implants that have some recession exposing the abutments as well as the implant bodies, okay? So we have several problems here. We have a lack of keratinized gingiva. We have no attached gingiva. We have a series of frenum pools in the area. We have a shallow vestibule. The implant positions are their implant positions. I mean, we're not changing those. They might be too close together, okay? Patient may have some parafunctional habits. So in a situation like this, we always have to have the debate, do we do a free gingival graft, or do we do a connective tissue graft, or do we do an allograft? I will tell you right now, I would not do an allograft with any of these mucogingival deficiencies around implants. Not because they don't work, it's just that, just biologically speaking, they don't yield the same result as autogenous tissue does. And I'm open to challenge on any of that. Not only that, they're much, acellular dermal grafts are much more technique sensitive. So for me, in a case like this, the debate's always connective tissue versus a free gingival graft. That's really the two options that I give myself. So once again, with health in mind, what gives you the best result? So for me, I reflected a partial thickness bed here, and I went with a free gingival graft because I can place it submarginally and not mess with the free gingival margin and possibly make it worse. I know with a free gingival graft, I'm going to get massive increases in keratinized and attached gingiva. We can adequately address the frenum pools. And I know over time, even if she still brushes hard or whatever, that keratinized tissue is still going to be there. So this is 2 weeks after a free gingival graft. This is at her suture removal. You can see exactly what I told you happened here. Lots of keratinized and attached gingiva, okay? No more frenum pools, much more maintainable tissue. So you'll also notice that we got some creeping attachment of the soft tissue that covered the implant bodies and the abutments. So we got a really good result here. Now, is this anything that's surprising? I will say this, when we get creeping attachment around teeth, it's not surprising at all because we've been studying that since the 1970s, as you can see here. You get quite a bit of creeping attachment around natural teeth. We haven't really studied it too much around implants. Not creeping attachment anyway. Soft tissue plenty, but not creeping attachment. So when we look at how many times this has really been studied around implants, the literature is very sparse. The article that I have comes from IJPRD in 2018, where we got creeping attachment on 2 cases. So it's just not studied. So here's one case for you, and I'll show you some more. So here's another similar case around number 23. Implants in good position. Implants got plenty of bone around it, but soft tissue wise, patient doesn't like it. It's a little bit sore, tender to the touch. So what we do, again, we just do a small little free gingival graft, and you'll see here, even though it's placed below the gingival margin, we still get that creeping attachment, which is really nice. So you can see this patient at 1 year, at 2 years, and then I lost track of her because she drove in from out of town for her post-ops and she got tired of doing that. So she sent me a bathroom selfie for her 3-year checkup. And this is what it looks like. It's still very, very stable. Okay. Very stable and healthy. Aesthetically, it doesn't look the best because it's a free gingival graft. But, we're talking about a lower incisor. When we look at other cases on the left side of your screen, you'll notice, once again, creeping attachment does happen quite a bit. I think it's definitely something that we should look into a little bit more in the literature, because we just don't talk about it that much. But free gingival grafts are very, very safe and not very technique sensitive. They have a very, very high success rate, hardly ever fail. So anyway, if you don't know how to do a free gingival graft, you should definitely add that one to your repertoire. Okay, let's talk about top teeth. Okay, bottom teeth are easy. You do a free gingival graft, you're going to get lots of keratinized tissue. What do you do about top teeth? Okay, so this is a lady very unhappy with her crown. Crown was placed about 20 years ago. Now she has the exposed implant components. Not very happy. She also doesn't want to have the crown replaced. Not yet. She wants the soft tissue addressed first. So what do? We have lots of inflammation around the implant, and the patient's not keeping it very clean. So the challenges here, we have thin facial tissue. We have a high freedom attachment in the area, poor plaque control. The implant position is a little bit more to the facial than I would like. And then, of course, like all of our patients, in situations like this, finances is an option. So what would you do? Interesting thing about, opinions in social media nowadays, I utilize things like Instagram just to kind of get a pulse on what people would like to do. So in this situation here, I just asked, my followers what they would do with this ailing implant. Would they fix it or remove it? And actually more people wanted to remove this implant than fix it. And then the people who wanted to fix it, they said that they would, about 3/4 of them would prefer a connective tissue graft over a free gingival graft. And I always wonder why that is. Why would you even want to take the implant out, right? Because that would cause a lot of damage, but it's interesting. And also, it was an interesting choice of graft, connective tissue versus free gingival. I always wonder what people's rationale would be. And the reason that is because I chose a free gingival graft in this situation. Not that it's the right answer, it's just what I chose, and I'll share with you why. So here we prepared the bed, and we placed the free gingival graft over the area. Now, at 2 weeks, this is what you're going to see. And I chose a free gingival graft just because, once again, I think it's important for me to get a lot of keratinized and attached gingiva. I value that as from a health perspective, and I feel better about that long term for the patient. I also didn't like the Freenapol in the area, because if you've ever done a soft tissue graft and had it fail in the aesthetic zone, it's a miserable recovery. And if the patient is adamant against not replacing the crown, you got to go with the safest bet, which is manipulating the marginal tissue as little as possible. So here we are at 3 months. Not the most perfect result, nobody's saying that, but at 1 year, very, very healthy. Here's our before and here's our after. Okay. Some people often have questions about kind of the funny, thick shape of it. The patient was okay with it, but if she wasn't, this would be one of those cases where you just grab a diamond burr and do a nice gingivoplasty to blend it in a little bit better. If she ever changes her mind about replacing the crown, of course, her result will be even better than that. So, moving on. When would you ever do a connective tissue graft? So there's several indications for that. So if we want to get a little bit more volume with our graft material, that's when you would do a connective tissue graft. Okay, so as an example, here we've got an implant number 6 that's cantilevered over to tooth number 7. And they did that to try to maximize the papilla volume. The problem is we still lost the facial part of the papilla. There's still a little bit of a black triangle, as you can see, but we lost the facial part of that papilla. So in this situation here, you're going to go back to the tuberosity like I showed you earlier. You just harvest a little piece of tuberosity graft. You have to deepithelialize it because it's going to go underneath the flap, right? You don't want any epithelium underneath your flap, so you have to deepithelialize your connective tissue graft. This comes from the tuberosity, and we're using a vestibular approach. So this would be a lot like the pinhole surgical technique that a lot of you guys ask about. So we're going to go through the vestibular approach, which is just a horizontal incision made at the mucogingival junction. So here we're going to drag the connective tissue graft into that papillary area and simply suture it. Okay. So 2 weeks later, it heals up so quick and very stable. Once again, stable connective tissue comes from the tuberosity. That's what he looks like afterwards. You can still see there's a small black triangle, but nothing like it was before. And this is a long-term result, you all. This is at 12 years. So a little bit more about connective tissue grafts. You don't always have to do a vestibular approach. Sometimes you can come from the other direction and make a sulcular approach. So here we have an inflamed tissue around implant number 8. The patient has a reasonably thick tissue, but it's really just, very inflamed and angry. So what we chose to do here is just transform that gingival biotype with a small little connective tissue graft. And I chose, because she had so much keratinized tissue, in this situation I didn't like the vestibular approach because you're going to have too much tension. Here what was better for me was a sulcular approach with a small tunnel. So here we're just, we already reflected our tunnel and prepared the bed. Here's our connective tissue graft going in. We simply suture it like that. And here's 13 years later, 2005 versus 2008. You can see we have plenty of healthy tissue at this point. Now, this case is similar to the other exposed implant case that I showed you a couple cases ago. What do you do here? We have the patient smiling. She can see, the abutment margin, and she's tired of redoing things. She's already gone with the stock abutment, a gold abutment, zirconia abutment. This is her 3rd abutment, right? She's even had her last 2 abutments were custom abutments. So she can't understand why she can't get the result that she wants. Now, the reason I give you that history is because a lot of people are like, well, just change the restoration. What do you do if you can't change the restoration, though, right? Or the patient is unwilling to do that? What are our soft tissue options? So when we look at the implant radiographically, this is not something that I would feel great about removing. So for me, we decided to just try to save what we have with the soft tissue graft. So here you can see that we've got some gingival recession. We do have adequate keratinized and attached gingiva. There's no frenum pull in the area, and we have a small soft tissue concavity on the distal facial aspect. So going back to our Instagram poll, when you look at this, even though the recession is the same as the case 3 cases ago, 89% want to fix this case versus 11% wanting to take it out. Why is that? My suspicion is because we have keratinized gingiva here and there's no inflammation. So that changes how people perceive the problem. But once again, in cases like this, people do tend to support a connective tissue graft over a free gingival graft. And I did a connective tissue graft in this situation. Just for those of you all who don't know, this is how we harvest connective tissue grafts. This is her. We just harvested it from the left side of her palate. And then we're just going to sharply dissect with 15 blades is how I like to do it. This is just going to be a nice little blunt dissection with a periosteal elevator. And then after that, the tissue is released from the palatal bone. Then we'll come back in and just sharply dissect the rest of it out of the donor side here. There you go. So now, just like with natural teeth, we have to get a burr. We actually have to plane down, the abutment to make a nice flat surface. It doesn't have to be a concave surface, but you want a nice flat surface. And because it is an abutment, you don't want to overdo it and weaken the material. And you don't also know, of course, if it's a very thin walled abutment, you don't want to expose, you don't want to perforate it either. So here what we've done is a tunnel flap, or the no-hole surgical approach. We've got our connective tissue inserted through the sulcus and then simply sutured with chromic gut sutures after advancing that tissue. This is what it looks like at 3 weeks after the sutures have already resorbed. And then here we are at 1 year. So here, what you can see here, pretty happy with the final results here. We got a nice cuff of keratinized tissue as expected. Coronally advancing that tissue didn't adversely affect anything too much. The patient's pretty happy. I'm sorry, this is at 1 year. This is her smiling. You can see now there's no more abutment exposure or anything like that. So going to our last topic, how do we create a lot of volume? Okay, when we talk about a lot of volume, what we're talking about is, you know, with soft tissue grafts, they tend to have some shrinkage, right? So if we have big defects, like what I'm going to, what's the best graft for that? So I'm going to introduce to you the vascularized interpositional connective tissue graft. So what this technique is, and here's just a short review. Here we have an implant that's going to be placed to replace tooth number 7, okay, right in that area. We don't like that concavity. The patient doesn't like it. When she smiles, you can see that it's kind of dark. So a brief rundown here of the VIP technique is we harvest, we harvest a connective tissue graft from the right side of the palate. And as we release it towards the anterior portion of the palate, the key thing why it's called a vascularized interpositional graft is because we leave the blood supply intact. So we do not take this graft all the way out like we did in the previous case. Instead, we maintain the blood supply in the anterior region and we just rotate the graft into place, as you can see here. Okay. Now, what we do is we leave a little bit of the lingual flap in place so we can tuck the graft underneath that lingual flap, like you see here. Close it primarily with Vicryl sutures. This is what it looks like from the facial and the occlusal views. Yes, I am aware of the gingival recession on the other teeth that we can correct later, but for now we're just trying to correct that concavity. And then this is what we're looking at after it's healed up. So you can see the volume that we've created with this VIP graft. So that's what it looks like in a small case, but what do you do in a bigger case? So the last 2 cases, I'm going to show you how much volume we can really achieve here. So the advantages of a VIP CT graft is that you can maximize soft tissue volume with less shrinkage of the graft material. So it's much more predictable. So last topic, malpositioned implants in the aesthetic zone. So going over this case, now our last 2 cases, we are definitely not in management positions. We're definitely on rescue missions. So let's do our first rescue mission here. So this is Katie. She's a dental assistant, and I'll save you the 10 to 15 minute story that I usually tell when we're live. But what happened here is, long story short, she had a failing tooth number 9. Her dentist was, her employer was a dentist, and he suggested placing an immediate implant with an immediate temporization. So what happened here is when he took out number 9 and placed the implant, he hit the root of tooth number 10. Long story short, both teeth eventually failed. And then after a series of bone grafts, she eventually got into a position where she's got 2 implants here, one for number 9 and one for number 10. So as we walk through here in the panel, you can see the implant contacting tooth number 10, which is subsequently treated with a root canal, which got rid of her pain, but the damage was already done and she eventually lost both teeth. Okay, here you can see the facial position of that immediate implant. And here's the panel after the implant and natural tooth have failed. And this is our situation as she presented to our office. Okay, so she's got a provisional restoration. She hates it. And unfortunately, she was getting ready this day that she came in. She was actually getting ready to get her final restorations. And she stopped by our office. We were across the street. Our colleague had referred her to us before the final delivery and wondered if we could help. And Katie wanted 2 things. She wanted the gingival margins of number 8 and number 9 to be even. And with our soft tissue grafting techniques, I told her that that was actually very predictable. The second thing she wanted, however, was she wanted papilla between 8 and 9 and 9 and 10. With the provisional off, you can see the papilla between 9 and 10 goes almost in a negative direction. So how are we going to get papilla in that area? So this is, I'm going to show you our approach here. Now, it's important to note what this thing looks like radiographically, because you can see how apically positioned the implants are. They're placed very, very deep, okay, at no fault of the oral surgeon, who eventually was able to grow enough horizontal bone to place these implants. But as you can see here, number 9 is placed, almost a centimeter below the CEJ of the adjacent tooth. So here it's important to note this chart from Team Atlanta, where when you look at 2 implants side by side, the average papilla height is only 3.5 millimeters. It's the worst possible scenario that you can have. Whereas a more favorable position would be implant next to a ponic. You gain an extra 2 millimeters of papilla height. The problem here is the implant was placed so deep, it's hard to cantilever over it, and based because of the biomechanical forces involved. So 2 implants were placed, and this is the provisional. So what do? Here, what we decided was the VIP technique, because we have poor existing gingival levels. We have nothing to do with this inherited case. Implant depth position is not good at all for us from a soft tissue perspective. She has not responded very well to the iatrogenic dentistry that's been involved. And then, of course, the management of the tissue with the abutment and crown, we just don't have a whole lot to work with. So let's go ahead and get moving here. We've got our facial and our occlusal views. Here we're doing the VIP CT graft, harvesting it from the left side of the palate. Here we're flipping it over the abutment on number 9, and I'm going to show you this surgery that we actually recorded her surgery back here in 2012, 13 maybe, I can't remember what year. But anyway, here after the connective tissue graft is flipped over to the recipient site, what I did is I made an incision in the middle of that graft. And the reason I did that is because we're going to utilize a really tall healing abutment on number 9 as kind of a tent pole to offer our graft some stability and some space maintenance. So we're going to slide that tall healing abutment through the slit in the graft that I made. So it's going to fit over that abutment like a turtleneck. And that's what you can see here. So now we have a nice, safe, and secure soft tissue graft. So here's the rest of our photos as we're going through here. Get primary closure. This is what it looks like from the facial aspect. And then what should have happened in an ideal situation is we remake the provisional bridge and have better contours, but I didn't coordinate very well at the time with the restorative dentist, and just did a poor job of communicating on my part. But we ended up just trying to create some relief there for some papilla. This is what she looked like at 12 weeks, which she could have looked better if we would have remade the provisional. But at any rate, we eventually got her dentist eventually got her into a final restoration, and this is at 5 years, and you can see that. Here we've got the gingival margins of 8 and 9 even, and then we actually have some papilla between 8 and 9 and 9 and 10. Not big, gigantic papilla, but we have something. So we have, here's time 0, and here we are at 7 years. And this is what we can do even when the implants are placed, a centimeter deep. So I felt really good about this result, as did Katie. Last case here. So let's talk about this. This is also the case that we started off with. So we have Lucas here, who's got 2 implants that are, of course, integrated, replacing number 9 and 10. His story is he got hit by a hockey puck and knocked out 2 teeth. So once again, this is a rescue mission. This is not soft tissue management. We are no longer in control. At this point, we do unfortunately have to rely a little bit on luck, and the luck that we're relying on is the patient healing, right? That's what we have to rely on. So this is Lucas smiling. He's got a high smile line. You can definitely see there's something going on there. His soft tissue position right now is horrible, and the quality is horrible. Well, there's no keratinized or attached gingiva, okay? So what do we do, and how do we do it? So the first thing here is recognizing that replacing the implants, trephining them out, we did not want to do that. I did not want to do that because they were integrated. As you can see here with it reflected, he does have some crystal bone loss, which is unfortunate, but restarting is not going to guarantee any better results. Matter of fact, it almost guarantees you an even worse result. So implants are placed deep again. Here's our VIP CT grafts. Now, because there's 2 implants, I chose 2 teeth. I didn't have to probably, but I wanted to get as much thickness out of this as I could. So we harvested 2 grafts, 1 on each side of the palate. This is what it looks like flipped over the sites. And then here, it's important to note that I de-epithelialized the lingual tissue there. So the connective tissue is laying on top of another bed of connective tissue. That's what it looks like here. And from the facial aspect, we're going to gain a lot of tissue here. This is what it looks like sutured up. And this is the occlusal view. You can see it's kind of a bloody mess. It's very hard to manage from a hemostasis perspective. Really even more difficult to get the photograph, but we were able to do that. This is what he looks like at 2 weeks. We can see a little bit of necrosis between on the mesial aspect of number 8, but overall, lots of soft tissue, which is really good. This is what he looked like at 8 weeks. Things are healing up great. Now he needs crown lengthening, which is we're still trying to talk him into. But at 12 weeks, what we're going to notice is all our literature and all our observations coming together. Earlier I said when you have a thicker biotype, earlier I said patients like, when we looked at the literature, the patients prefer keratinized gingiva. They like the aesthetics of it better. And this demonstrates that. With Lucas smiling, you can see that even though the soft tissue margins are better, the quality isn't good because it's not keratinized and it's unattached. I'm sorry, it's not keratinized. It's just not keratinized. So when he smiles, you can see that it's kind of a dark shade over number 9 and 10. So the good news is, a couple things, is he's probably going to eventually do crown lengthening, but if we do that, it's going to create a mucogingival deficiency. So we have to get more keratinized gingiva over that number 9, 10 area, maybe over 8, 9, and 10, which is good because on the left side of your screen, you can see he's got a little bit of a bulge of soft tissue in the palate that he hates. So in this situation here, we just simply took the graft from that bulge that he hates, and then we just did what I call, jokingly, the Oklahoma graft, because I'm from Oklahoma. We did the Oklahoma graft, and we placed it over the facial aspect here of number 8, 9, and 10. This is what it looks like fully healed. You can see a lot of beefy, very thick, stable, keratinized tissue. And then here we are with his new provisional restorations. And if he got crown lengthening, his case would look even better. But right now, he's just sitting on these provisionals, which is fine by me because this is where he started. This is where he ended. And this is him smiling before. And here we are now. So now he's got a great smile. All he's got to do is the crown lengthening if he'll do it. But right now, he looks really good. The facial concavity between around 9 and 10 has been corrected. No more shadowing. It just looks nice and healthy and stable. So that's it. Ending right at close to 12:30 as promised. And if you have any questions, which undoubtedly you might, just hit me up on Instagram or on either of these 2 accounts, and I'll get those questions answered. But thank you very much for your attention. I appreciate it.
Thank you so much, Dr. Wong. That was amazing. We do have some questions here if you have some time right now to answer them.
Of course.
On first case, do you usually provisionalize before placing permanent crown?
Yes.